Hi everyone. Today I deal with the new topic that is electrolyte imbalances. In this section I deal about which are the important electrolytes in the human body as well as what are the imbalances and what happens because of that and also its management. First of all, see the electrolytes. Electrolytes are various chemicals that can carry positive or negative electrical changes in our body. As you all know, there are many important electrolytes are there in our body. They are sodium, potassium, calcium, phosphorus and magnesium. So these electrolytes, it has its own way of functioning in our body. That is what I said. It carry the positive or negative electrical charges and make the functions in the human body. And what is the significance of these electrolytes in our body? When it comes to consider about sodium, it controls the water distribution throughout the body and it is a regulator of extracellular fluid volume. When it comes to potassium, it is important in neuromuscular activity. It influences both skeletal, cardiac and cardiac muscle activity. As you've heard of this, there is a electric potential, otherwise electric activity, otherwise electrical transportation is the cardiac cells or brain cells and skeletal system. So potassium has a very significant effect in the body. Then when it comes to calcium, it play a major role in transmission of nerve impulses. Then when it comes to phosphorus, it helps in the function of muscles and red blood cells as well as it helps maintain the acid balance, nervous system and metabolism. Then magnesium, it is an activator for many enzymes and helps in carbohydrate as well as protein metabolism. Then we start with the what are the imbalances of electrolytes. As we see many the electrolytes are sodium, potassium, calcium, phosphate and magnesium. So what is the imbalances? Imbalances always be it decreases or increases. So first and foremost the hyponatremia. The hyponatremia in the sense decreased sodium level in the blood. So here we see what is that. The sodium deficit of that is serum sodium level is less than 135 milliequivalent per liter. As we know, the normal sodium level in blood is 135 to 145 milliequivalent per liter. That is 135 to 145 is the normal range in the human body. So when it comes to less than 135 milliequivalent per liter, there is a term we say hyponatremia. The major risk factors are use of diuretics. As you know, diuretics are Lasix or furosemide we say. Then loss of GI fluids, that is gastrointestinal fluid losses. Then renal disease, adrenal insufficiency and excessive administration of dextrose. The major signs and symptoms are anorexia, nausea, vomiting, headache, lethargy, confusion, muscle cramps, muscle weakness, seizure, papilledema, dry skin, tachycardia and hypotension. So assessment and diagnostic findings. How could we identify if the patient has hyponatremia in the sense? The first and foremost thing is history and physical examination. Through the historical history aspect, we collect about what are the baseline causes that may lead to hyponatremia. And on physical examination, we can identify these significant features. That is, the signs and symptoms what we saw. That things you can identify through the physical examination. The investigation is the blood investigation, that is laboratory examination. We check the serum sodium level, that is sodium level in the blood. So it will be most often less than 135 milliequivalent per liter. Then similarly we identify the urine specific gravity. It will also be less than 1.010. Normal specific gravity is 1.010 to 1.020. Okay. For the management of hyponatremia, we supposed to go with sodium replacement. As it is, there is a decreased sodium level, so we supposed to replace with the sodium solution. So sodium replacement should be done. That may be by hypertonic saline, that is 3% to 5% of hypertonic solution administered through intravenous lane. Then also we restrict water intake, that is 800 ml for 24 hours. Next, what is the nursing management? So regarding the nursing management, that is, first of all, we monitor fluid intake and output. So we supposed to strictly follow the intake output chart. Should follow intake output chart and see what is the intake and what is the output. Also see the fluid balance. Then check the body weight daily. Then vital signs monitoring. Monitor for sodium level, that is serum sodium level should be monitored. Then monitor signs and symptoms of complications. Then check the urine specific gravity. Identify the patient at risk. Also, if patient is able to take orally, encourage foods and fluids with a high sodium content. So the next condition is a hypernatremia. Hypernatremia itself says there is an increased serum sodium level. So when patient has the serum sodium level more than 145 milliequivalent per liter, then we diagnose as a hypernatremia. So then what are the major factors that leads to hypernatremia? Otherwise, sodium quantity that increases in blood are water deprivation, increases sensible and insensible water loss, ingestion of large amount of salt, hypertonic tube feeding, diabetes insipidus, profuse sweating, and heat stroke. Then, if the patient has hypernatremia, what are the features or what are the clinical manifestations we can see are the patient is visibly with more thirst and elevated body temperature, swollen dry tongue, hallucination, lethargy, restlessness, irritable seizure, and hyperactive. As you know these terms, thirst means patients always feel of having fluid. Then blood body temperature will be increased. Then the tongues looks swollen as well as it is dry. Hallucination means there is a false perceptions, that is patient may hear something or patient false visualization or something. That is a sensory problem. Then lethargy looks always tired, restless. Then irritable seizure as well as a hyperactive. Then in the assessment findings on examination we can identify the serum sodium level will be more than 145 milliequivalent per liter, as well as the urine specific gravity also more than 1.015. And we see the what is the management for hypernatremia. First of all, infusion of hypotonic solution or isotonic solution. As you know, hypotonic solution in the sense there is a decreased salt, otherwise decreased solute than the solution. Otherwise, isotonic solution, there is an equal proportion of solute as well as the solution. Then diuretics. Diuretics, there is a, for example, Lasix, that is furosemide we can administer. Then decompression in case of diabetes insipidus. And nursing management, like here also the foremost thing is we are supposed to maintain intake and output. So the strict monitoring of IO chart, then avoid taking high sodium content food, treat hyperthermia, then careful administration of IV fluids. That is, we supposed to see whether it is a hypotonic, otherwise only isotonic solutions only we have to administer. Accidentally if we administer hypertonic solution, patient end up with again increase the sodium concentration. Then monitor the changes in behavior, monitor sodium level, give sufficient water with two feedings, and check the urine specific gravity. Whatever the patient clinical features or whatever the complications we can expect because of that, all these things will be prevented through the clear nursing management. Then third aspect is the changes in potassium level, that is hypokalemia, that is decreased serum potassium level is termed as hypokalemia. Here the serum potassium level it is less than 3.5 milliequivalent per liter is called hypokalemia. As we know the normal serum potassium level is 3.5 to 5.5 milliequivalent per liter. The major risk factors are diarrhea, vomiting, then gastric suction, corticosteroid administration, hyperaldosteronism, bulimia, osmotic diuresis, steroid administration, polyuria, and poor intake. So these are the factors that is a decrease the serum potassium level. The signs and symptoms of hypokalemia are patient seems fatigue and anorexia. As you know, patient will always be lethargic and fatigue and being tired. Then nausea or vomiting. Patient have the feel of vomiting or patient will be in the nauseated stage. Then muscle weakness. Then decreased bowel motility. There is a bowel mobility will be altered. Then cardiac arrhythmias. As it is known, there is a potassium has a significant effect in the electric potential, so especially in the cardiac system as well as the nervous system. So when there is a decreased potassium level, patient will be ended with the chance of cardiac arrhythmias, abnormal electrical activity in the heart. Then the increased sensitivity to digitalis. There is a digitalis is a drug of cardiac glycoside. So there is a sensitivity to digitalis also generated. Then leg cramps and hypotension, polyuria, nocturia, and ECG changes. Especially in ECG, there is a widened, otherwise presence of U wave. Usually, in the ECG there is only P wave, QRS complex, and T wave. Then in case of hyperkalemia, there is a seems of presence of U wave and also something widened of T wave is there. And paresthesia. These are the main features of hypokalemia. Then what are the assessment findings? The significant finding is the serum potassium level will be less than 3.5 milliequivalent per liter. Then we can manage it by intake and output monitoring and observe for excessive intake of high potassium and oral or intravenous replacement therapy. That is a potassium chloride or potassium chloride administration we can do by strict monitoring. The nursing management also assess the patient condition, because patient anytime may be end up with any complications like arrhythmia or any patient end up with hypotension. Also always monitor the patient condition. Then monitor patient at risk. Then monitor the ECG, that is arrhythmia, chances of developing arrhythmia, and also the ECG shows the significant variation because of hypokalemia. Then monitor potassium level and administer potassium intravenously. So next is the hyperkalemia, that is a imbalance of increased serum potassium level. So here we see the serum potassium level, it is more than 5.5 milliequivalent per liter, we termed as hyperkalemia. So the risk factors are olivuric renal failure, potassium sparing diuretics, hypoaldosteronism, and high potassium intake. All these situations, the increased potassium level will be stored in the blood. The signs and symptoms includes vague muscle weakness, cardiac arrhythmias, flaccid paralysis, paresthesia, irritability, ECG change, nausea, intestinal colic, and diarrhea. So when there is a hyperkalemia, significantly the ECG changes. Here we can see the peak T wave. So if you take a ECG, peak T wave will be present in because of hyperkalemia. Similarly, arrhythmias also we can expect because of increased potassium level. Then assessment diagnostic findings like the serum potassium, that is more than 5.5 milliequivalent per liter, and on ECG we can significantly identify the peak T wave, and on arterial blood gas analysis we can analyze the variations in the acid-base imbalance. Then on management, what is the management? First of all, obtain ECG and identify the exact picture of the patient condition. Then restrict potassium containing diet, monitor blood pressure, administer calcium gluconate. Calcium gluconate, when administer calcium gluconate, it will regulate the potassium levels. Then administer sodium bicarbonate, insulin, and hypertonic dextrose. The nursing management for patient with hyperkalemia: observe the signs and symptoms and assess. Serum potassium level should be monitored. Prolonged use of tourniquet should be avoided. Advise the patient not to exercise the extremities before the blood drawn. Administer IV fluids. Potassium should be mixed nicely with the IV fluids. That is, we are supposed to dilute the potassium chloride in the IV fluid and administer. Most often we use dextrose solution for administering the potassium. Then restrict potassium containing diet. These are the nursing management. The next is the imbalance in calcium. In that, first we see what is hypocalcemia. The term itself says decreased calcium level in the blood. So significantly, if we see the serum calcium level less than 4.5 milliequivalent per liter, then we say it's a hypocalcemia. The risk factors of hypocalcemia are hypoparathyroidism, malabsorption syndrome, pancreatitis, vitamin D deficiency, alkalosis, and excessive administration of citrated food. The signs and symptoms are patient have numbness, tingling sensation, mental changes, seizure, spasm of laryngeal muscle, ECG changes, and muscle cramps. Then we can identify this. So the diagnostic test we can perform is laboratory investigation, identify serum calcium level. The calcium level will be less than 4.5 milliequivalent per liter. Similarly, serum albumin level is supposed to assess, and ECG, that is electrocardiograph. Then management for hypercalcemia are, in case of severe deficiency, IV administration of calcium and vitamin D therapy, aluminum hydroxide, and calcium supplement through diet. This is the management for hypocalcemia. Then for nursing management, identify the risk patient and monitor for calcium level. Then we have to take seizure precautions. That is, we have to provide side rails, and also we identify the high risk patients and provide the precautionary measures. Then airway should be closely monitored, dietary advice, and avoid alcohol, caffeine, and smoking. The next is the hypercalcemia. Hypercalcemia in the sense the serum calcium level more than 5.5 milliequivalent per liter. So the risk factors of hypercalcemia are hyperparathyroidism. Then regarding this one, we'll learn more about the endocrine system. There is a thyroid problems and parathyroid problems. Then another is a prolonged immobilization. Patient will be confined to bed for more period. Then malignant neoplastic disease, large dose of vitamin D administration, thiazide diuretics, then overdose of calcium supplement. These are the things that leads to hypercalcemia. Then the major signs and symptoms include constipation, anorexia, muscle weakness, polyuria, polydipsia, decreased attention span, decreased memory, renal stone, neurotic behavior, and cardiac arrest. On assessment, we can identify serum calcium level will be more than 5.5 milliequivalent per liter, and through in the electrocardiogram we can identify if patient have developed any arrhythmia or abnormal electrical activity in the heart. Then X-ray, we can identify the presence of osteoporosis, urinary calculi, then perform urine test to check the calcium level in the urine. Management, the aim, otherwise goal of treatment is to decrease serum calcium level and reversing the process causing hypocalcemia. So what is the root cause for cause that leads to hypocalcemia? That's supposed to be identified and treat the cause. So that is the first aspect, that is treatment for the underlying cause. So if it is a problem with the parathyroid, means we supposed to treat that. Then administration of IV fluids, especially sodium chloride. Then mobilization of the patient, that is if the patient's what is that, immobility is the problem, means we supposed to try to mobilize the patient. Then restrict dietary calcium intake, and administration of intravenous phosphate, it can cause reciprocal drop in serum calcium level. Then administer furosemide with the fluid administration. Then administration of calcitonin, especially cardiac patients cannot tolerate sodium load, means administer calcitonin. The nursing management is monitor the patient who are at risk, then increase the patient's mobility, encourage fluids, administer drugs and IV fluids as prescribed, discourage calcium-rich diet, and monitor electrocardiogram and vital signs. Next is the imbalance in phosphate level. So first of all, hypophosphatemia. When there is a hypophosphatemia, that is decreased phosphate level in blood. So we can see when the phosphorus level is less than 2.8 milligram per deciliter, that is termed as hypophosphatemia. The major risk factors like anorexia nervosa, alcoholism, diabetic ketoacidosis, respiratory alkalosis, and hypoparathyroidism. Similarly, the elderly patients who are unable to eat, that is the elderly who take decreased food, then prolonged hyperventilation, thermal burns, and vitamin D deficiency also leads to hypophosphatemia. And see the signs and symptoms. The main signs and symptoms are paresthesia, muscle weakness. These are the simple terms you can identify easily what it is. We know that. Then bone pain, chest pain or angina vitae, Then patient seems confused. Cardiomyopathy, there is a myocardial degeneration or the myocardial dysfunction. Then respiratory failure, apprehension, numbness, seizure, and finally end up with the most of them coma. Then on the assessment, we can identify the serum phosphorus level will be less than 2.8 milligram per deciliter, and X-ray shows skeletal changes. The management is monitor serum phosphate level, oral supplement, that is a phosphate included foods are supposed to be administered, intravenous administration of phosphorus for severe deficit. Here the nursing management, that is almost the identify the assess the patient at risk, because we are supposed to whenever we take care of the patients, we have the sense to recognize whether the patient is risk for particular situation. Then monitor the vital signs, take measure to prevent infection, intravenous administration of phosphorus, that is whatever the prescription that's supposed to be implemented. Then monitor hypocalcemia, monitor serum phosphorus level. And finally, there is a hyperphosphatemia, that is a increased phosphorus level. When it is increased phosphorus, there is a serum phosphorus level more than 4.5 milligram per deciliter, then we termed as hyperphosphatemia. So for that, what are the factors that leads to hyperphosphatemia are acute and chronic renal failure, patients who are undergoing chemotherapy, then hypoparathyroidism or diabetic ketoacidosis, excessive intake of phosphorus, vitamin D excess, and respiratory acidosis. These are the factors that leads to hyperphosphatemia or increased phosphorus level in the blood. So we can identify by laboratory examination. On laboratory examination, there is serum phosphorus level will be more than 4.5 milligram per deciliter. The major features are patient will experience tetany, tachycardia, precipitation of calcium phosphate in organs, that leads to muscle weakness, tingling sensation, and signs of hypocalcemia also present in the patient. Management is administer allopurinol to prevent nephropathy, restrict the dietary phosphate, and patients certain times undergo dialysis, then monitor for hypocalcemia. Then nursing management is identify and assess the patient at risk, prescribe low phosphorus diet, that is a oral supplement supposed to be with the decreased phosphorus level, monitor urine output to rectify whether patient end up with the nephropathy or not. If the patient's urine output decrease means the kidneys are affected, so supposed to patient may be needed with the dialysis. Then avoid phosphate containing contents like especially laxatives. Then teach about signs of hypocalcemia. Then next is the imbalance in magnesium level. So first of all, the hypomagnesemia. So when there is a serum magnesium level less than 1.5 milligram per deciliter, then when we term as hypomagnesemia. So see the what are the factors that leads to hypomagnesemia are chronic alcoholism, hyperparathyroidism, hyperaldosteronism, then malabsorption syndrome, nasogastric suction, thiazide diuretics, aminoglycosides, excessive use of vitamin D. Then the patients will be presented with neuromuscular irritability, insomnia, mood changes, disorientation, anorexia, vomiting, increased reflexes, tremors, convulsion, and tachyarrhythmias. Tachyarrhythmias are maybe ventricular tachyarrhythmia or atrial tachyarrhythmias. That is, patients presented with increased heart rate and all. So assessment like laboratory examination shows serum magnesium level will be less than 1.5 milligram per deciliter. The management is administer magnesium salt orally, intravenous administration of magnesium for severe deficiency, monitor vital signs, monitor cardiac function, and monitor urine output. So here the nursing management includes mild deficit correct by diet. If it is a mild only means through the diet we can modify the diet and we can balance the magnesium level. Then provide safety precautions, monitor conditions of airway and ability to swallow, educate the patient if abuse of diuretics or laxatives, Then dietary advices, how to balance the magnesium level. Then the final condition is hypermagnesemia. That is the magnesium level in blood is increased. So that is serum level of magnesium is more than 2.5 milligram per deciliter. So here we see what are the factors that may be leads to magnesium level increases. Then that is first of all oliguric phase of renal failure, then adrenal insufficiency, excessive intravenous administration of magnesium, hemodialysis with a hard water or dialysate high in magnesium, and excessive use of antacids. These are the risk factors that leads to hypermagnesemia. Then patient will be seen with flushing, hypotension, drowsiness, hypoactive reflexes, depressed respiration, cardiac arrest, and seems coma and muscle weakness. That is if these features are shows, if you are not treating on right time, patient end up with a coma. Then on assessment, that is a laboratory examination, blood investigation shows serum magnesium level more than 2.5 milligram per deciliter. The management includes avoid administration of magnesium to patient with renal failure, discontinue administering magnesium if patient develop hypermagnesemia, then hemodialysis magnesium-free dialysis, and administer loop diuretics. Loop diuretic example is furosemide and normal saline or calcium gluconate. All these things that will help to regulate the magnesium level. The nursing management is identify the patient at risk and assess, avoid giving magnesium containing medications, educate the patient about abuse of drugs, example renal failure, then monitor vital signs. So that are the major imbalances. This is a summarized document of sodium imbalance, that is hyponatremia. What is hyponatremia? It is defined as the plasma or serum sodium level less than 135 milliequivalent per liter. Then what are the risk factors or etiological factors? It is mentioned, that is kidney disease, adrenal insufficiency, GI loss, use of diuretics and metabolic acidosis. Then what are the clinical manifestations and laboratory findings and management? These are already revised one, but it is in the single page how it is. In a nutshell, it is shown it's about hyponatremia. Similarly, in the further hypernatremia, its definition is increased serum sodium level. Then its causes, manifestations, lab investigations, and management is shown here. Then potassium imbalances like a hypokalemia and for further hyperkalemia, and calcium imbalances like hypocalcemia and hypercalcemia. A special major aspect only shown in a nutshell. I hope you all understood about the electrolyte imbalances, and thank you.